Good afternoon, everyone. Thank you so much for joining us for the Cancer Survivorship Program Roundtable. We are hoping to get a lot of good feedback on use of cancer survivorship in your programs. So you've got that up on the, okay. Okay, and I think it's important because I think with the state of Ohio working on their cancer survivorship or cancer program goals for the next decade, that it gives you an opportunity to kind of give feedback on what you're doing out in the field. And so that's what we're really hoping to hear from you. And I think the thing that Scott and I were so impressed with when we worked on this grant is the number of people who were really dedicated to working in this area. Some had been in it a long time. Some of the people we talked to had been doing this for 20 years, been working in oncology programs. Others had been really fairly new at it within the past year or so, but there was definitely a commitment by people to, you know, spend time and work with their patients in a way that it was to the patient's benefit and to help them through what is a difficult process. And so what I think the first thing we'd like to kind of find out is, no matter how long you have been involved, what do you think the most meaningful part of your work with oncology care patients is? What do you think makes the biggest difference to them? And you all can, I'm going to let Scott run the technical side. So.
Well, the intent for today is for this to be a completely open discussion. We want to hear from you guys. It's your chance to influence the Ohio Comprehensive Cancer Plan. I believe Emily, who we were hoping would join us today, I believe they're in the process now of rewriting is it a 10-year plan?
Yeah, the 10-year. They decided to go with 10 rather than 5 years. And so they're right in the middle of that, and I think...
So we really don't have an agenda today. We have some seed questions because really it's about capturing your guys' input, your thoughts, where could things be improved. So we are recording the session, but just so we don't miss a great comment, because we are trying to feverishly write down some notes as we go along, but we want to make sure we don't miss anything.
Yeah, and Linda, I know you're on, and you actually run the committee for the input, and I don't recall if it's the survivorship group that you run, but I don't know if you'd like to kind of share what your role is and what you're hoping to do. I know that. Yeah,
she may just be listening in. I don't have. But Linda, we'd love to hear your comments. Angie and Dory the same. We'd love to hear your feedback as well. And I can unmute you guys if you'd like. Dory and Angie, you guys are unmuted, so we definitely want to hear from you.
Angie? Hi.
Hello.
Tell us, I know you have not done the oncology care as long as some of the other people have. Oh, Dory, you're talking, right? Okay, wait a second. We're just muting, so.
Okay. Dory.
Okay, there we go. Angie, can you hear us now?
Yep, I can hear okay.
Okay. I was taken with when we spoke with you that you really had a good handle on the survivorship program, and I just thought you'd want to give some input as to what you think the most valuable thing is that you do for the program and how you intend to, work going ahead with the change of the accreditation standards changing.
Well, thank you for that. I don't know that I feel that I do a good job, but I try to. We are just trying to grow our program and get more people involved here at Adena. I think it's really important for our patients to get in touch with other resources that could be available to them, especially with ongoing issues related to their previous oncology treatments. And sometimes these things seem to be overlooked in our routine follow-ups, just talking about their cancer markers or their CAT scan results as they come in, just especially every 3 months or even longer. So having these other longer discussions to actually sit down and talk to people about what's going on and how they've adjusted throughout their survivorship, I find to be the most important.
So you feel that giving them follow-up, but also pointing them in the right direction and kind of giving them a place to, or, you know, someone to fall back on. Do you find that you have a lot of one-on-one contact with the patients?
Especially during the survivorship program, yes. But I can also see them for part of their care team for their follow-up. It's not separate in our program here. So I may work with one of the physicians to see the patients as part of their routine follow-up, but I also saw them in survivorship and know what they told me during those appointments that I can carry on those conversations with them at a later date.
Right. Dory, what about you?
Wait, hold on here, Dory. Let me get you unmuted. All right, Dory, you're unmuted.
Hi, thanks. I represent Ohio State, and we've had a pretty comprehensive program here for several years. And one of the more meaningful things that we do specifically in survivorship is providing that holistic, comprehensive care to patients, which is part of doing the care plan visit, but also we have clinic available to any patient for any reason to really do a phenomenal assessment for unmet needs and do a lot of health promotion and health coordination. In light of the new changes coming with COC program standards in 21, we are well positioned to have multiple resources available for our cancer survivors. And we believe that we bought into that model prior to the COC coming in, which is why we can leverage where we're at. But we definitely believe that survivorship is a really crucial component. And I know you guys touched on it last week, and something we'd like to continue to touch on is that, you know, it should be standard of care, but it should have reimbursement for it. And we do find pieces of that. I'd be interested to see how others do it as well, but we do a lot of evaluation management codes for our nurse practitioners and for other specialties, but to have it recognized as its own entity, I believe is going to be crucial going forward, particularly in light of global pandemics and budget justifications and things like that. I think we need more national recognition from key players like CMS on the importance of survivorship.
Yeah, I would definitely agree that the reimbursement, that's what we heard from all the centers that we talked to, is even those like your own that are more electronic, shall we say, in putting together the survivorship care plans, still have a fair amount of manual work on it. And there's no question that the survivorship program itself is labor intensive because it is so one-on-one. Do you find that your patients really appreciate the fact that the James has built a program just to support them as they move out of their treatment phase?
Yeah, I mean, all of our patient satisfaction, all of our anecdotal data are really indicative that patients are grateful and appreciative that there is a comprehensive program behind them to really help them transition from active treatment through at least that first year of initial post-treatment adjustment to living without cancer anymore. One thing that we are definitely interested in doing is looking more at living with cancer. So for metastatic survivors, does that mean that's something that we're transitioning into as well? But it is a really well-received program. A lot of times we hear, I wish I had known about this sooner. That's something that we're trying very hard to leverage and connect patients in. We're not requiring that they have to come to us only for completion of treatment and survivorship care plans. We're trying to integrate them throughout their treatment phase. So whether they have a curable intent, whether they're metastatic or other even end of life, we'd like to work with palliative and other things. So my role isn't just survivorship. My role is the whole cancer support services. So I have a lot of the umbrella programs underneath me, and we're trying to make a more integrated feel for the patients, so that they are enveloped in sort of a comprehensive model of care.
So you said that patients may mention that they wish they had known about it sooner. How does your survivorship program work in relation to the overall oncology treatment? Is it something that they get introduced to as they're finishing their treatment, or is it something that they are made aware of earlier and they just don't make use of right away?
All the above, honestly. There is a push from a lot of oncology teams at the end to be seen in our survivorship clinic, but we also work really hard at making sure that clinical teams and patients and caregivers even are aware of all the services we have, because they're not geared just to that post-treatment phase. They're geared for from diagnosis and beyond. So we do a lot of work with marketing, internal and external marketing to some degree, of our programs and services. So probably it's a little bit heavy on the back end of mentioning it around the time of treatment, but we're trying to move it forward so that patients are aware of it. Patients and caregivers are aware of the services we have at a much earlier time point.
Okay. And Angie, what about you all? How do you let the patients know that you have this program that helps to, support them as they move out of active treatment?
One of the ways is through our care coordination / chemo education meeting at the beginning. Before they start their treatments, we talk about our different programs, including the genetics program that we use with Ohio State, but also with the survivorship, to kind of give them an idea of what's to come later on down the road. But usually those people, our patients, are delayed until finishing towards the end of their initial treatment. Most don't come or even talk to me until after that point. And it's mostly pushed forward through our nurse navigators, who let us know when these people are approaching the end of their current treatments so that we can prepare for them in the survivorship clinic.
Okay. And as part of your survivorship clinics, is it that's something that every patient goes through, or the patients choose to go through?
For us, it's the ones that are of curative intent, stage 1 through stage 3. Some stage 4s, obviously, for lymphomas. But no, we offer the program to them. Some people decline, but we've had some really good participation rates right now.
Okay, and as part of the survivorship treatment, or not treatment, but the survivorship plan, do you coordinate any of the post-treatment services, say with social service agencies or with education groups or anything like that, as part of the survivorship care plan?
We do. We remind them of all their services, like with the social worker available, and relaying them to those outside, or actually their internal sources within our cancer center, but they look to outside groups depending on what the patient's needs are. We do remind them that the dietitian is available, and we've had people participate in that more towards healthy eating habits and survivorship diet. So we do remind them of those services. Not everyone chooses to take part and meet with them again like they do during our care coordination visits, but there are some that do.
Okay, and Dory, what about you? You provide the survivorship care program for any patients that are a level 1 through 3, stage 1 through 3?
Yes, similarly to what Angie said, we have the nurse practitioner that meets with them, and then they do a couple of things. They obviously review the care plan if it's that type of visit, and if not, both visit types have an evaluation assessment for unmet needs, and then we create referrals and we generate those sometimes to external sources and sometimes within. We have a social worker that can meet with them. We also do a lot of goal setting. We have patients try to work with our NPs to create 2 goals. So we have some ongoing communication with them about how to meet those personal goals when they finish. We have a lot of educational support. So we have some new modules that we're doing through Epic called My Health Companion. That is a self-driven program for about 1 to 3 months after they complete. We're just piloting that right now. We have a lot of education materials, and then we have similar to probably to other institutions, we have a pretty robust experiential and programming where, they can get introduced to anything from yoga to any sports things. We, a lot of the health and wellness initiatives, we have a Garden of Hope, we have support groups, those kind of things. So we try to make sure they're well connected to any resources they might need. And if they need primary care, we would connect them to primary care and try to facilitate care coordination for them.
So how long does the survivorship program last? Is it 3 months post-treatment, or do you have it open-ended, or do you invite your patients to come back and touch base with you a year out or anything like that?
It's variable. We do not have a set curriculum for patients of how they want to do it. At our institution, we do separate surveillance from survivorship, so they're still getting their surveillance visits with their primary oncology teams. In survivorship, it really just depends. We have patients who are really doing as well as can be expected when they finish, and they really do not want to engage in a lot of services, and they feel that they're adapting fine. And then we have some patients who really do want to have that level of support and come back to us within a certain time frame. It really just depends on what our treatment plan is. So if we ordered a medication that would require some follow-up, that would certainly trigger it. If we want to check in on their progress of how they're doing with their goal setting, or we've referred to a few things, we will check in with them. So it really is personalized to what the patient requires to adapt and really have their needs met.
Are you planning on continuing to use the survivorship care plan under this restructured model going forward? You said that you're testing out new of the health and wellness stuff. Are you going to stay with the survivorship care plan? Do you think that there's any, if you think there's a benefit to staying with it, would you cut it back at all to make it easier for you to produce?
I think there's a couple of things. So the short answer is yes. We are going to keep that as part of what our metrics for putting together our standard for the COC. But more importantly, we do get feedback from patients that they really do appreciate the information that we share with them. I do think that there are probably changes that need to be addressed with the treatment summary and care plan to make it more user-friendly, integrate it more into the EMR, to make it easier on the clinicians and staff to get the information needed in there. It does, as you alluded to, and I think Angie did too, it takes some time to put these together. It doesn't matter how integrated it is into the EMR, it still requires a level of detail by staff to go enter some information in there. So we are going to do that. But I do think that rather than a document as the sole focus, I think what has emerged in literature and from our experience, and I'm sure in others, it's the conversation that you have with the patient that normalizes what they're about to experience as a survivor and addresses any of their unmet needs, as well as laying the groundwork that they may not experience it on any certain time frame. They may develop something 2 years later that could be, fear of recurrence or any of the sort of effects from their late and long-term effects from treatment. That is probably the most crucial part of what we do, rather than handing them a document. They do like the document. In our experience, one of the more robust things that they like is actually having a really concise history of what their cancer treatment was, so that should they go anywhere else, they have a really succinct copy of what they experienced. But we do get feedback from patients that they do really enjoy having it. But again, I think one of the things that they benefit from the most is the actual conversation and connecting to resources and referrals rather than just having a document, if that makes sense.
Oh, yeah. What about you, Angie? Do you find that the care plans are something that are appreciated, and are you planning to keep it as part of Adina's program? And if so, would you recommend any changes?
I would completely agree with Dory. I think a lot of patients do appreciate the document moving forward, even if we share them with their primary care doctors as well. But I do think some changes need to be made to it, and how to incorporate it into our EMR system is a whole nother world. But I do think we'll continue providing them to the patients along with that conversation, and just helping them live a healthier lifestyle, and getting to know what expectations are, how often they're coming back, what tests are going to be ordered, so that they can look forward and not always be thinking just about their cancer. Like when it's time, yes, this is when you're coming back, this is what to expect. Those kind of things I think help with the patient's anxiety returning to the clinic as well.
Okay. Yeah, that's a good point. Okay. So, Angie, if you're going to continue to use it, recognizing that it's labor intensive, would you have any recommendations about how to streamline the care plan itself? Because it sounds like the benefit is that it's patient focused, and as being patient focused, it seems to be designed to answer their questions and to give them a summary. Is there anything that you think could be done more easily as far as the survivorship care plan?
I do think it would be more beneficial, especially when it comes to staging in our documents, what that means for that patient. When they come to their appointments, we have some people who never knew what their stage was, or at least that's what they tell us. So to kind of walk them through and tell them, yes, you're a stage 3. Well, what does that mean? Somehow it would be nice to incorporate that in, just an explanation of the staging system for them, in very simple terms, of course. I know our EMR does not have any discrete fields to pull into any documentation like what I hear Epic does, or the continuity of care document. I do think we could make it a little simpler for people and not have such detail, but there are certain aspects that a patient doesn't know what that means, doesn't know what this drug is. So just to take those out and make it like clear and concise for them, I think would be beneficial. I think maybe the document, sorry.
Go on, Angie.
It's okay, go right ahead, Dory.
I was going to ask Dory to pick up on what you just said, because you're like two ends of the spectrum as far as the technology and the size of your programs and stuff. Dory, do you find that the Epic system does lay out the various stages and it gets fed into the survivorship care plan, or do you have anything that you think Angie could make use of in their program?
So, I mean, Epic does do the best that it can to sort of assist you in doing it. And so when we do staging, Epic modules allow for the clinicians to put in clinical or pathologic staging. And now it's actually integrated where pathologic staging actually is being auto-generated based on path reports. So we are lucky in the sense that the staging is already created. But there are always discrepancies sometimes between clinical and path, and Angie's 100% right. It is astounding the number of patients who are like, I never knew that was my stage, or didn't really understand it. So I think to piggyback on what she's saying, not just pulling in the information, but how do we share it with patients that makes sense to them? So we've written a manuscript, we're trying to get it published, but if you look at the health literacy rates of what our country has versus what we put on a care plan, it's astounding. College level education to understand a care plan. There's a lot of information on there that is very high level, very difficult for patients to understand. So do we need to start providing glossaries? Do we need to put it down to a 5th grade reading? I mean, that's difficult to do when you're talking about something like an adenocarcinoma, but how do we explain it in a way that makes sense to them and is useful to them? You know, I think we've created a document sometimes just for the, I'm not saying us or individuals, but I think a lot of the care plans have been created and done as sort of a check mark to the COC. And I think we need to reframe that, how we're thinking about it, and how do we make this the most useful to the patient? How do we do some of this? Like to Angie, it's not just, is Epic creating the stage? What does the stage mean to the patient?
You know, you put your finger on, Dory, what, you know, you both know that Scott and I do quite a bit of work with reporting out of systems. I mean, that's what we're showing organizations how to do, so they can report to CMS or to Medicaid or whoever they need to about their technical capability. And that's something, Dory, that Scott and I have talked about all the way through this program, is that the care plan that you all produce to meet the COC accreditation and the continuity of care document that is put out by organizations to meet the CMS requirements are very, very, very similar, even though the audience would be totally different. Like, you wouldn't expect a patient to look at a continuity of care document and to pull all that technical clinical information out. And yet, when I looked at a lot of the survivorship care plans, that was something that concerned me, is that there was probably more similarities than there were differences. I mean, there's definitely the areas where you all put in how you get support documentation, or, you know, support services and stuff. But I too felt that it seemed to be at a very high technical literacy rate, and I wondered about that. I wondered if anyone's going to comment on the fact that it might be more than a lot of patients could really take in. Do you find that to be true a lot, Dory, or do people ever ask you questions, or do you just get the sense of the deer in the headlights?
I think a little bit of all the above. We went through, and the manuscript that we're trying to get published at the moment is, we just looked at all of them, ASCO, Journey Forward, and pretty much the outcome is that they're all this high level. And, you know, I think that's the benefit, going back to, at risk of repeating myself, that's why the conversation with a provider, I mean, our model is using a nurse practitioner. I know others use nurses. I am a nurse. I'm not denigrating nurses. But somebody who's got a clinical background, because that's the time that questions get generated, right? It's that conversation with the patient, trying to figure out what do we need to share with them, but it's got to be dynamic. It can't just be us lecturing to the patient about, like, this is what we have to cover in this visit. It's really, we try to come at it from a perspective of, like, this is for that, like, this visit is for them. How do we help whatever their deficit is? How do we get them to there? So we do see deer in headlights sometimes, but we'll back up and we'll, you know, go back to, you know, saying it in different ways, and each NP has sort of like a different way of kind of discussing that with the patients. But we try really, really hard to not just give them information in that survivorship care plan visit. We try to do it with the conversation. We also have a survivorship booklet that we provide, which has a lot of patient education in it, but has a lot of infographics in it in case they're visual learners. And, you know, now we're trying to create a lot of digital content to help. So we recognize how hard it is for them to understand the document. And so I think that's what's galvanized us to figure out other mechanisms to educate them besides using this document. And
wow.
I just want to say one other quick point, is we've asked I know other people have said this, Deb Mayer said this, others, and so it's not unique, but we've asked so much of one document, right? We've asked it to be for the patients. We've asked it to be for the primary care. We've asked it to be for the oncology teams. And one document cannot be all things to all people. It can't. And so I think that's part of the trouble we've come into with survivorship care plans is who's it really for? And we've taken the position that this document's really for the patients. So how do we get it into their hands that makes sense to them while still following ASCO template, COC guidelines? How do we make it useful to them?
Oh, I couldn't agree with you more. You said it so beautifully. Angie, what do you think? Do you feel the same way with your patients that maybe the document almost gets too technical for them, or do you feel like they appreciate having it, but they have more questions, or what?
I do think that the document is too technical for our patient population. I am not from this area, and I've definitely learned over the last year that even things that I feel like I've really brought down to a lower level still are going over people's heads. So I'm trying to figure out that for myself on how to explain things to people in a way that they understand them. So the document a lot of times is very overwhelming for a lot of patients. So we go through it step by step, which does take a lot of time, just to get it to the point where they can understand it, not just for accuracy, but to make sure they understand their staging, what's going on. Did you see the genetic counselor? Did you understand the testing results and things like that as well? But I do think I have a long way to go.
I think your guys' comments kind of feed back to this question here. What do you think the most important element of the successful survivorship program? And I've heard the word patient conversation probably repeated, and that sit down, that face to face. I agree. That's when you're going to know that patient understands, what they need to do to stay healthy going forward. So
yeah. You all really summarized, I think, what we felt as technical people working with this program. When I reviewed, we saw quite a few survivorship care plans, and that was the one thing that just struck me is I'm not sure the audience was always clear as to who it should be, because the intent to send documents to subsequently treating providers is going to need different information in it, and it just seems to get very technical very quickly. So I think that's great. We've got a couple of other groups that we're going to be talking to that couldn't make it today, but is there anything that you feel, it sounds to me like if I had to do takeaways, that there's two things I've heard you say. One is the survivorship care plan needs to be simplified and focused to information to the patient. That'd be number one. And the CMS, the question of how it's used as accreditation standards.
Yeah.
And is there anything else that you would like to, Dory, I very much, please let us know when your reports or your studies get published, because I think they're excellent companion pieces to this grant. And I think that we would really like to reference them when they come out. And I'm sure the state of Ohio would be very interested in it. But is there anything else that you feel should be kind of takeaways from the whole idea of survivorship care plans?
So, yeah, I think that, the number one thing is really clarifying, as we just said, who the care plan is for. And then if there's other information we need to get to primary care, if that's treatment summary things, figuring out a different mechanism for that. Because let's be honest, I don't know most primary cares that actually read however long the care plans are. They want certain information, and I think we need to figure out what that is and how to provide it in a different way, in a more integrated way into their own EMR, so that they're not digging through their chart looking for something. I think reimbursement is really important, and we touched on that. And I think the idea of survivorship care plans came from a really great place. Patients love them. But to the comment that you heard.
Wait, Dory.
Yeah.
Okay, I got the reimbursement, but what was the last one you were just talking about?
Yeah,
Survivorship what?
So the survivorship care plans came from a really great place, but there wasn't a lot of evidence to suggest how to implement them or the utility of them. And so I think that's what a lot of institutions have been trying to do for the last 10 years is meet a standard, but figure out how to really implement it. And so I think that those are the biggest challenges around survivorship care plans. And then the next phase, now that we're, we are lucky enough to do, but I think some institutions may struggle with this, is how do you provide all the resources now required in COC to really galvanize survivorship, and how do you use all these resources and in a really thoughtful way for patients. And I think one of the things that, while survivorship care plans have its place, survivorship has to evolve. And I think now we have to start being really thoughtful across like the state of Ohio and even the nation about sharing data of our survivors. And really, we have some idea of what they're experiencing, but how do we personalize the care plan? Like, we can give them a document, but how do we really put an algorithm into place for cardiac toxicity and heart failure? How do we really move our patients on change management, behavioral changes? How do we do goal setting? And databases are useful. And so I don't know what the state of Ohio has planned for data capture. I mean, obviously, like each institution has a registry, and we also report that data. But I really think survivorship is going to have to go into a place where we're able to personalize the care to the patient, not just from a physical standpoint, but from genomics, psychosocial, socioeconomic. I think it's putting together the whole picture of who the patient is to having a balanced life.
Can I ask you, if we wrote up something on the reimbursement portion for CMS, because this is, as you know, this is a huge area for CMS, is the whole question of care coordination and how to do it better. Mm-hmm. Do you get any payment at all right now for the survivorship care program, a direct payment?
We do, because we use nurse practitioners and we bill evaluation and management codes.
Okay. What about you, Angie? Do you get any reimbursement for your survivorship care program?
We do. I'm a nurse practitioner, and I'm the one who provides the appointment. It's not the additional time that it takes to put together the care plans and things like that, but for the actual appointment, yes.
Okay, so if we put in something about reimbursement, it should go to the concept of supporting the additional time that it takes to prepare these documents and to prepare for the program.
Some reimbursement for the non-face-to-face time.
Yeah.
So there is a code. There is a code you can use, and I cannot remember it off the top of my head, so I'll find it and send it to you guys. But we have chosen not to do it because of the financial toxicity to patients from adding on an additional fee for doing this.
Oh, good point.
Yeah.
Good point.
It does exist to some degree. It's not specific to survivorship care plans. That's been a choice that our institutions made to, let me clarify, if it's medically necessary, we would do it. But it's a lot of chart abstraction, and it is time spent, but we do not routinely use that code.
Okay. Yeah, I had not even thought about the copay aspect, which is, I think, what you're referring to.
Yeah. Because
they do have that additional code for time now for work that's done in preparation for a visit. So, do you all have any last thoughts you want us to add? Because we can do kind of an epilogue to the white paper to include this. And as I said, we've got at least one other large group to finish talking to, and I think another one that couldn't make it today. But if you have anything else that you'd like us to add, we would be more than happy to do that.
No, the code is 99358.
Yes, yeah, you're right. Now, what about for the state of Ohio moving ahead in their decade-long plans for care, for cancer care? Is there any overwhelming message that you feel it would be important to improve how oncology care is delivered, or basically how this ongoing support is delivered to patients? Would you want the state to, what would you want the state to know or look at?
For me, I think that we would want the state to acknowledge that survivorship is a phase and that there needs to be more education, research, and support in this, and really starting to highlight that this is not just a nice thing to do or to have, that survivorship is essential part of cancer care.
Okay, that's okay. So essential to cancer care.
Mm-hmm.
Okay. What about you, Angie? If you had one message for the state about the importance of survivorship planning, what would it be? What do you think would improve the health or you know, the ongoing outlook for the patients that you deal with?
I think it would be really important to understand, with the growing number of survivors in Ohio, the needs are going to continue to grow, and we need to have the right people and the right resources in place to care for our patients, especially with people living longer and living even with stage 4 cancers or metastatic cancers longer. We need to have the right amount of support for these people and their families.
Okay. Yeah, I would agree with that. All the areas that it's hard just to say to people, oh, well, you're done with treatment, therefore we'll see you in 5 years or something. Does not go over well. So, what about family support? Do either of you try to do that as part of your program? And if so, do you think that's inherent in what you want to see in a survivorship program, some type of support for the families?
So it's not specifically, we don't have the patient's family always come to survivorship visit. They're welcome to, but we do have a lot of resources for caregivers. We have all of our psychosocial programming is available for caregivers. All of our Students Care for Life activities, which is our experiential programming, is open to caregivers. So we have a whole Caregivers Month in November of activities that support them. So we do try to recognize that they are an integral component to the survivor's well-being.
Okay. What about you, Angie? Do you work with families at all?
We do some. A lot of people do bring their family members with them to their care coordination visits or survivorship visits. Right now, especially with the pandemic, we don't have a lot of resources available for people in person. And I think especially our community doesn't really have access to the internet or online resources. So right now, I really feel like we're kind of struggling taking care of a lot of the extra needs and of both the patients and the family members. But I know that's our goal. We just need to get there.
Yeah, so Angie and Dory, it sounds like we have two sides of the coin to that same question. Here in Columbus, we've got a lot of those social services available to the family, where down at, Adena and you get outside of, Columbus, that's just not the case for many of the rural programs. That's interesting. All right.
Yeah. Well, We appreciate your input. I think what we'll do is add an epilogue to the white paper. And as I said, we've got at least 2 other groups that are planning on commenting too. And send it out to you all. But I just hope we can stay in touch because, as I said, you two have been an interesting. One of you has one of the largest cancer programs in the country, and the other of you is trying to meet the needs of a rural population that needs as much support, but you may not have the same financial wherewithal and everything else. So I think it really gives a very solid understanding of what is necessary across the continuum. But the bottom line is you're both really engaged in your patient population and their needs, and I think that's the biggest thing. So we really appreciate it. Scott, do you have anything? I know Linda's on, but she probably can't talk because the connection's not good for her. But
we had a.
And who else do we have? Lori. Lori, we can see you're on. Are you?
And Lori, I've unmuted you. Do you have anything you'd like to share? You know, Lori, which organization are you with?
Lori.
Can you hear me?
Yes, ma'am.
Oh, okay. All right. I'm sorry. I never, I didn't receive the link to join the meeting until it was occurring. So I came in midway and I didn't want to be disruptive. I apologize. I am from Mercy Health in Northwest Ohio is my region.
Oh, hi, Lori. Yeah, Linda had told us, or not Linda, Emily had said that you were handling the education portion and working on developing some type of education module. Is that correct?
Yes, absolutely. Mm-hmm. And we've
would you tell everyone what it is that you were doing? Because Lori had a different part of the same grant, but their focus was different. And so why don't you just kind of explain what it is that you've been doing and, you know, where you hope to head. And hopefully the dialogue today is helpful to you. So go on.
Sure. I will try to keep it brief, but basically we took the guidelines of COC and NAPBC and then the requirements for deliverables for the grant from the Ohio Department of Health. And we just, you know, researched best practices and evidence-based guidelines for survivorship education sessions and took a lot of adapted material from George Washington University and American Cancer Society guidelines and put together essentially a checklist for, we started with 4 cancer types, breast, colorectal, head and necks, and prostates because they have the most long-term and late effects. And we put together a checklist where we go through the 4 pillars or components of survivorship with prevention or with surveillance and care coordination and all the things that, you know, everyone else knows about. But one component, I don't know if everyone does, and we started doing it for the grant to show in to evaluate gains in knowledge from the survivorship education session, but it's been very helpful for us for data collection and get together with our survivorship subcommittee and discuss ways to improve, is that we took, actually I believe the University of Michigan developed the PLANS acronym, Preparing the New Survivor, a pre-test and a post-test. So all of our survivors take the pre-test and then they take a post-test, and there are questions that are very basic, 10 questions that are like, I know which healthcare providers to call with questions about my cancer and its treatment. I am clear on which providers to call if I have questions about my symptoms. I know what symptoms or problems I should be looking for. I understand what my follow-up tests are. And we kind of briefly look that over at the end of their appointment and make sure before they leave that we can address any of those where they have checked that they don't necessarily feel 100% confident. We also do a little follow-up call or check with them a couple weeks later because, as everyone knows, the the patients, even in survivorship, probably retain about 10% of what you tell them. They're so overloaded and overwhelmed by information that we send them home with an abundance of print materials, and at their leisure they go through them, and then we check back with them and ask if they have any questions about the materials, and after they've had a chance to let everything soak in. So that's been very helpful, evaluating the gains in knowledge pre and post test with the survivorship visit.
Hey, Lori, using that tool, would you agree with what Angie and Dory were saying about the fact that maybe the survivorship care plans are written at too high a level to be as helpful as they could be to the patients?
Well, Dory made an excellent point about how it's a document that is going to many different demographics and audiences, but it, and we're expecting it to serve one purpose. So I do think it could be more simplified, not only for the patient, because the primary care providers, as she said, don't really have the time or to read the entire thing. And then furthermore, I mean, there's lots of evidence, and a lot of them will admit that the primary care providers aren't necessarily have the breadth of education and knowledge on what survivorship entails, and so they would love to have a simplified version of what they need to be doing for their patients. Even I think it would be helpful too with patients, could have the same diagnosis or whatever, but they may have different surveillance plans for the 5 years or longer following. If there was something that kind of bridged the gap between the oncologist and the PCP about, here's the surveillance, we'd like to, or that we recommend following, and, for when they should get their next screening or whatever, based on, family history and genetics and all kinds of variables that don't necessarily make that a standard surveillance or screening period for the same two people that have the same diagnosis. So I do think simplifying it for primary care docs and patients could be nice. Then again, I think a lot of patients just like knowing that they're armed with that and equipped with that document. If they do have any other medical needs or go elsewhere, they know they have it in its entirety, even if they don't necessarily understand everything that it entails or all the information it provides. But that's another reason why I feel that the pre and post test, where we ask them very basically that they understand, who's responsible for what and what symptoms to look out for, and we're sending them home with that information, they feel a lot better knowing that they have it with them to refer to, even if they didn't absorb it in the 60 to 90 minute survivorship education session.
Okay, well, I'll tell you what, if you have any summary that you want us to send out to this group who's working on the other side of the grant, we'd be more than happy to do that. But I think overall it's a lot of good feedback, so we'll see where that goes. But we are at the end of the hour, and I think we thank everyone for their participation. We have a couple of other contacts to do, but we should be wrapping up the report and the recommendations by the end of next week. So again, thank you all, and look for the follow-up, okay? Have a good one.
Thank you all.
Bye.
Thank you. Bye.